Hi, everyone. Welcome to Johns Hopkins University Virtual JS Day. So you're currently in the Lightning Talks session. We're very glad that you're here, and we're very excited for our panelists today. My name is Anton Kvit. I'm a data analyst at the Johns Hopkins School of Public Health, Spatial Science for Public Health Center, and I'll be the moderator for today's session. First, I'd like to introduce our co-sponsors. JS Day is sponsored by the Johns Hopkins Center for a Livable Future, which is an academic research center focused on the intersection of public health, the environment, and the food system, and also the Johns Hopkins Spatial Science for Public Health Center, which is an academic research center focused on the development and application of spatial analytics, GIS, and spatial statistics within the context of public health. Before we start, I'd like to go over just a few housekeeping notes. So we'll be recording this webinar, and we'll make it available on YouTube and other sites after the event. Each presentation will last about 5 minutes. And so please post any questions for the presenters in the Q&A box. And we won't have time for individual questions after each presenter, but we will have a Q&A session at the end for all our presenters. We can ask the questions then. So these are our speakers today, and we will start with Stacy Liu, who's a PhD student in the Department of Population, Family, and Reproductive Health at JHSPH.
Thanks, Anton. So hello, everyone, and welcome to the Lightning Talks today. Today, I'll be presenting about one of the aims in our larger evaluation, which is a project that's evaluating the impact of the pandemic on summer food service program sponsors and meals participation in Maryland. The aim that I will be specifically focusing on in this presentation is exploring the impact of the pandemic on Maryland SFSP meals participation and operations from June, July, and August in 2019 to 2020. Next slide, please. So in 2019, there were 43 SFSP sponsors in total, but in 2020, the number of sponsors actually decreased to 33. The number of sites also decreased by about 200 sites between 2019 and 2020, yet the total number of meals served increased very dramatically. So in 2019, about 3 million total meals were served through the SFSP, but in 2020, about 9.5 million total meals were served, which is like a 210% increase in total meals served. And the maps on this slide illustrate these changes. So each of these bubbles on these maps represents an SFSP sponsor site and how many total meals they served. On the left, there's 2019, and on the right, there is 2020. Between these two maps, you can see that there's been a huge increase in the size of the bubbles, representing more total meals served by each site than in the 2019 bubbles. This is not included on the slide, but I want to briefly mention some findings from additional mapping that we did about the distance between CEP eligible schools and SFSP meal sites in 2020. There was a significant difference between urban and rural sponsors in the number of in the distance between CEP eligible schools within 1 mile of SFSP meal site catchment areas. And most urban schools were within 1 mile of an SFSP site, whereas most rural schools were within 3 miles of an SFSP site. Next slide, please. In conclusion, like the key takeaway that I want you to take away here is that there was a huge increase in the total number of meals served between 2019 and 2020 by the SFSP. And this is with the pandemic occurring in the spring in between this time. This huge increase is also despite those decreases in the number of sponsors and meal sites that were distributing meals. This dramatic increase can be largely attributed to the flexibilities afforded to sponsors by the COVID-19 pandemic-related waivers issued by the USDA, which were specifically evaluating in our larger mixed methods evaluation. And I'm sorry, my cat has been moving around this whole time. We hope that these findings can help to inform future policy recommendations, specifically about the extension of waivers, which enabled sponsors to serve so many meals during the pandemic. And we also hope that these findings can help to target programmatic and policy changes to fit the unique needs of different geographic regions. For example, differences between distances to sites in urban and rural areas. All of this adds to our ongoing work about Maryland SFSP sponsors and their experiences and operations, which we've been doing since 2018. And we're actually continuing our work now as we're currently in the process of surveying Maryland SFSP sponsors about their transition to hybrid or fully in-person meal service. And we'll be starting those interviews with them really soon. And just continuing to use mapping to explore trends and changes in summer meals participation and sites. I want to also take some time right now to thank our funders and our partners. So all of this work would not be possible without funding and support from the Johns Hopkins Lerner Center for Public Health Promotion Community Scholars Grant Program Award. Next, I would like to thank our partners at Maryland Hunger Solutions, Michael J. Wilson and Julia Gross, Rachel Borman and Jordan Everett. I'd also like to thank my colleagues at the School of Public Health, Dr. Susan Gross, Caitlin Harper, who is a doctoral student in international health, and Sophie Shuby, who is a recent MPH graduate. And finally, of course, I want to thank our partners at the Center for a Livable Future who do all of this wonderful mapping work for us. So Jamie Harding and Caitlin Miziazik, thank you so much for all of your help and support with creating these wonderful maps and conducting spatial analyses. Thanks so much for your time and attention.
Thank you. So up next, we'll have Caitlin Miziazik from the Center for Livable Future.
Thanks, Anton. Yes, hi, my name is Caitlin Miziazik, and I work at the Johns Hopkins Center for Livable Future. I'm going to present today on a dashboard we made displaying results from a nationwide survey of food policy councils on their response to COVID-19 in 2020. So just a quick background, at the Center for a Livable Future, we have a project called the Food Policy Networks Project. And the goal of this project is to really support the development of state and local food policy. The project team works directly with food policy councils, which are defined as networks of stakeholders that are sometimes sanctioned by government, or they may work independently of government, and they work to address food-related issues and improve their local food system through policy. Food policy councils work at many different geographic levels. Some are at the city level, some at county, state, regional, and tribal nation. They take many shapes, forms, sizes, but again, ultimately working to reform local food system policy. The Food Policy Networks team maintains a directory of all councils across North America and surveys them on a pretty annual basis to get a sense of where new councils are popping up, where councils may have disbanded, what their policy priorities are, what funding looks like, and so on. And most recently, they included questions related to COVID-19 and how councils may have pivoted their work given the pandemic. So from this survey, we created a dashboard to display some of the results of the survey. Next slide, please. And so this is a screenshot of the dashboard. So it includes a map front and center of where all the councils that responded to the survey exist, and then some interactive charts. And I'll walk through some of those findings and show a quick screenshot of how you can filter the data as well. So just a few highlights from the survey. 198 food policy councils responded to the survey, and you can see the spread of those on the map of where they exist across the US. And for reference, there are just over 300 documented in the online directory across North America. 68% of food policy councils reported operating at a local level, so county, city, or both. 19% focused on multi-county or multi-state regions, 11% at the state level, and 2% within tribal nations. 38% of food policy councils reported using a racial or social equity framework to guide their work, and 63% of councils had less than $10,000 in an annual budget. So many of these councils are doing a lot of their work with very few resources. Next slide, please. So then we can filter the data using this dashboard to see where councils are located that correspond with certain characteristics. So here I have highlighted councils that addressed, looking at topics addressed in policy work, looking at food chain workers. This was around 60 councils. You can see this is all interactive, and that's about 32% of councils. So it was actually a pretty big increase compared to previous years, and really shows how the pandemic highlighted the issues with labor policies and became something really important for councils to focus on. As you can see, the map changed, so we can see where councils who focused on this policy priority are located, what their budgets look like, and whether they had a racial equity framework, and so on. So this dashboard, well, one last thing I'll just point out is at the top, you can also filter by geographic focus. So again, those councils that are at the county level versus city or state, and then also by organization type. So those that are embedded in a university or in government or nonprofit. So this dashboard really allows councils and others that are interested to really dig into the data and understand where and what type of councils exist and the type of work they're doing related to COVID. So many times councils will reach out asking the team who's doing what or who has similar funding structure or working on similar policy topics. And this allows councils to filter and dig deeper into the data and make those connections and really learn from one another. Next slide. So we did the FPN team did another round of surveys this past summer, and they're working on analyzing that data. The results in this dashboard are also available in a full report on their website if you're interested in learning more. We also have a map of all the current food policy councils in the directory, as well as a time series map showing how councils have really kind of exploded over the last few years. And special shout out to Jamie Harding, who is really the dashboard mastermind and the GIS specialist at CLF, and to the FPN team for letting us share this project with you all today. And thanks so much.
Thank you, Caitlin. Up next, we'll have Adam Lee at the Center for Government Excellence.
Sorry, I was muted. I'm Adam Lee. I work at the Center for Government Excellence. I have been a member of the coronavirus resource team for about 1.5 years now. And one of my responsibilities is to manage the US dashboard. So this project is actually now featured on that dashboard. And the objective of the project was to design and develop a web application to showcase COVID-19 tribal nations data, which was supplied by the Johns Hopkins Center for American Indian Health. Next slide, please. This is a screenshot of the US map dashboard. If you've been following any county level data throughout the pandemic, you may be familiar with this dashboard. What we did was add a tab at the end called Tribal Nations, where you can find this embedded web application right in the dashboard. So you can find this dashboard by navigating to the coronavirus resource website or by following either of the 2 links at the bottom. I can post it in the chat later if you're interested. The bottom link actually takes you to the standalone web application. Since it is just embedded in the dashboard, there is a standalone version as well if you're more interested in this one specifically. So this application was pretty much entirely built using ArcGIS Online tools. The data is hosted on ArcGIS Online, and the web maps from ArcGIS Online were used as well. The application itself was built using Esri's web app builder tools, which I highly recommend for anyone who's new to GIS spatial web applications, because it lets you get your feet wet in web application building without needing to learn JavaScript or get into any coding or anything like that. Since this is an interactive web application, I can't really show off all of the features here, but in this static image, I could highlight a few key features. So this is the default view showing cumulative cases using bubbles over tribal lands, but the user can also switch between cumulative deaths, total doses administered, and % fully vaccinated. There's also a search bar up in the top left, which actually searches the feature layer for specific tribal lands and will zoom to that area if you search it and select one of the suggestions that it gives. Next slide, please. So the data for this map is manually collected by Center for American Health volunteers. And we get this data from all publicly sourced locations, such as social media, tribal run websites, radio broadcasts, and other public sources as well. Throughout the design process, we worked with the Center for American Indian Health to make sure that this data is being represented properly. Since they're the most familiar with this data, we thought it was important for us to make sure they were part of the design process throughout. We officially released this web application on Indigenous Peoples Day a little over a month ago on October 11th. But although it was finally released, the work wasn't done because, as we know, coronavirus data is still constantly changing around the world, and that's also true for tribal nations data. So we committed to updating this application on a weekly basis. So the process for that, in short, I receive a CSV file, which I then process through a Python script, which outputs a shapefile. And then I upload that shapefile to our public GitHub account, which you can go check out if you wanted to take a look at the shapefile yourself. Every step after this is essentially automated. So what happens is that we have an automatic routine that checks to see if that shapefile has been updated. If that shapefile does not match the old shapefile, it uploads that shapefile to convert it into a hosted feature layer view, which in turn updates the web map, and then that in turn updates the web application. Those three things all happen pretty much in quick succession of each other. The manual input that it takes to actually update this map only takes a couple of minutes, really. I want to take this opportunity to give a big thank you to the Center for American Indian Health for, of course, providing the data, which would not be, it would be impossible to make this application without this data that they have put in so much work to collect, and also for collaborating with us on the design of the application. I also wanted to thank Esri, of course, for providing the tools necessary to build this and for providing some hands-on support in creating the weekly updates for the application. Finally, I want to thank my peers at the Coronavirus Resource Center for supporting me in this project every step of the way. Like I said, if you want to check this app out yourself, you can go to either of the links down at the bottom. Let me know if you'd like me to post that in the chat.
Thank you, Adam. Up next, we have Michael Desjardin at the Spatial Science for Public Health Center.
Thank you, Anton. So my name is Michael Desjardins. I'm a postdoctoral fellow in the Spatial Science for Public Health Center in the Department of Epidemiology. And I'm also currently the chair of the Health and Medical Geography Specialty Group of the AAG. So hopefully I see some of you in New York City in February. I'll be talking about briefly this project that I just joined a few months ago, where we're using smartphone survey and GPS data to inform smoking cessation intervention delivery. So the idea is that we're using smartphone-based assessments in combination with continuous GPS tracking to inform smoking cessation intervention delivery and participants' daily activity spaces. So the idea is to recruit a cohort of smokers, track their activity spaces, see where they're smoking and not smoking, generate geofences based on high-risk smoking areas, and use these geofences to enable these intervention messages to hopefully improve smoking cessation, reduce the amount of time that they're smoking throughout the study period, and hopefully help them quit overall. So first, we have this cohort that was collected a couple of years ago. We'll be collecting or recruiting new cohorts in the future, but this is more for a proof of concept. So currently we have 149 adults between 18 and 26 years old. So we're focusing on young adults for now. We've seen an increase in smoking rates among young adults due to the advent of e-cigarettes and vaping and so on, but we're just focusing on cigarettes for this project for now. So our current cohort has participants that have reported at least 100 cigarettes smoked in their lifetime and currently smoking at least 1 cigarette per day for at least 3 days per week. So our main kind of approach that we're using right now is to compute geofences from kernel density and zonal statistic-based approaches. And this is, next slide, please. And this is done for each participant. So it's not done for the entire data set. It's tailored for each participant to hopefully improve smoking cessation at the individual level. So here we have an example of one participant where we generated geofences using this kernel density zonal statistic-based approach for different time periods. So we have on the left here, this person smoking between 3 and 6 p.m. and on the right smoking between 6 and 9 p.m. So these geofences are dynamic. You know, there's different patterns, space-time patterns of smoking for each participant. And so we didn't want to just use, you know, one geofence for the entire day or for the entire week. So we want to take 2 or 3 weeks of data, generate these geofences, and create an application where we're passively tracking them. And if they enter this geofence, we give them a smoking cessation message, and you know, kind of look at the efficacy of this over time. So here is just some examples of how the geofences look. We're looking at San Francisco, where our current cohort is, generating these geofences around census blocks and drawing a 100-meter buffer around the blocks to create this geofence to consider the inaccuracy of GPS locations. Next slide, please. So personalized geofences based on the time of day and high-risk census blocks may improve intervention message delivery. There's some evidence of this in the literature. We know that smartphone assessment and GPS tracking data can be used to inform intervention message delivery by or using this in mobile health studies. This is a very popular and hot topic in geography and GIS right now, using GPS tracking to look at exposures. Here we're looking at smoking, looking at social distancing and so on for COVID. So if you have this data, it's very interesting and very impactful. So this method will ensure that the delivery of intervention content is tailored to the unique risk patterns of individual participants rather than looking at the entire cohort at once. So the current goal is to recruit new cohorts after our proof of concept, the methods and so on are published, and we will be developing an automated phone application in future research, part of the R01 that's funding this work. And just a quick limitation, as you might have guessed, it relies on self-reports of the participants of smoking and non-smoking events. So I would like to acknowledge Amanda Lucan, who's a PhD student in the Department of Mental Health, and the PI of this work is Dr. Johannes Thrull in the Department of Mental Health. And thanks to him for adding me to this project to, kind of improve and work on the spatial side of things. So again, thanks to the NIH for allowing us to do this work, and hopefully these cohorts will be across the US and in Europe and so on. So thank you very much.
Thank you, Michael. Up next, we have Eliza Gruss, who's a student at Johns Hopkins University MS and GIS program, and also is a national map liaison at the US Geological Survey.
Hi, so I'm Eliza. I'm in my last semester at Johns Hopkins GIS program, and I also work full-time for the USGS in their National Geospatial program, and I'm the national map liaison for New York and Pennsylvania. So I'm going to go over a project I've been assisting with. It involves developing a screening tool to assist with site selection for deployment of mobile storm sensors in Pennsylvania. The project objectives are to develop a spatial screening tool to pre-identify ideal bridge over water locations for deployment of mobile sensors in advance of major storms across the state. And the purpose of these sensors is to capture water level data during anticipated flood events. And this will assist with our cooperator needs, such as flood risk awareness and mitigation. So the screening tool starts with over 27,000 bridge over water locations, and these were weighted according to 6 factors. So what we were looking at are, is it a scour critical bridge? How close is it to a densely populated area? How many hurricanes have tracked near it? Are there historical flood event data nearby? How close is it to flood insurance study locations? And also, how many historical disaster declarations have there been in the county where the bridge is located? Next slide, please. So these weights were then used to create a web app application that shows the bridges with the highest resulting weights. So the map indicates the 50 highest weights across the state, the highest in each of the 56 watersheds in the state, and also indicates the highest bridge, the highest weighted bridge in each of the 67 counties across the state. So all these bridges were displayed as points that were overlaid on a statewide surface that averages the weighted values for each bridge location. And this is also known as an inverse distance weighting method of interpolation. So this visualization tool, it was kind of a first cut at it. We used it back in September for replacement of mobile storm sensors during Hurricane Ida. Next slide, please. So our next steps for this project are to potentially incorporate additional data sets or factors into the weighted analysis. We're also going to look at refining the analysis by developing custom weights for select factors. So some might be weighted a little more heavily than others. And we also want to look at the sites that have the highest weights and take a more detailed look at them and work with our project cooperators to determine how effective the screening tool is at identifying sensitive locations that are in need of additional data collection during storms. So I just want to thank the project cooperators too, the USGS Pennsylvania Water Science Center, the Federal Emergency Management Agency, and the Pennsylvania Department of Transportation. Thank you.
Thank you, Eliza. Up next, we have Jonathan Dandois, who is a senior JS analyst at Johns Hopkins Facilities and Real Estate.
Yeah, good afternoon. We'll use GIS and facilities and real estate to support a wide range of aspects of managing, operating, building on campuses across Baltimore City, Homewood campus, Bayview, East Baltimore Hospital campus. And our GIS includes building information, asset information, utilities, building interiors. This is all internal, internal map services, internal ArcGIS platform to help support our business. We've got a lot of different layers. I think it's a lot of fun we have with GIS, much different pace than the rest of my fellow presenters today, but we have fun with GIS and make a lot of cool maps in the process. Next slide, please. The core of this is an ArcGIS enterprise portal that's hosted internally to our network. We use a number of different planimetric base map layers, imagery services to provide a jumping off point using GIS, a friendly mapping interface to lots of different information systems. That might be a document management system, building floor plans, or other utility infrastructure systems. Next slide, please. For example, we've been collating vast amounts of AutoCAD and civil engineering data about underground utilities across all of our campuses. These are often in disparate files from different projects. Organizing them in GIS in one place is incredibly valuable to operations and construction managers, so they don't have to go keep repaying to have the data surveyed over and over again. We can always just keep it up to date in our GIS, and it makes these fun rainbow spaghetti maps that probably break a few rules of cartography, but they're really valuable to our managers. Next, please. Over the past year, we've done a huge effort to import all of our building interior space data from AutoCAD drawings from our space management system at Homewood into GIS. So floor plans are geo-referenced for each building with a vast amount of space and spatial information about who's using that space, the square footage, and this can really be collated and indexed and sorted in a view that's really not possible in any other system. We can look at how space is allocated for the Krieger School versus the Whiting School across the whole campus in one view, and our planners and architects are just kind of like, they're blown away every time they look at it. So that's always a fun experience. Right? We're like, that's really cool. Next slide, please. We take some of this data, not sensitive business information, but a good amount of it from planimetric base map information, vegetation and trees for the Homewood campus, and publish that to the Sheridan Library's GIS and Data ArcGIS online portal through the help of the data services team there. We update that about once a year, but that's tagged as an authoritative data set to be used by Johns Hopkins students and staff for classes, for projects. If you can't find that, it should be pretty easy to find. There's maybe about 10 or a dozen layers. I'll be updating it again, January or so. And I think that's a good resource. We also put in some very high resolution aerial imagery. This one is from February 20. It looks like it says there, but I've got some from October of this year. So just a few weeks ago. It's some pretty nice high quality imagery. Next slide, please. We also make static maps and cartographic products for different resources. Some of these are internal projects. This one we had a lot of fun with. We worked with Johns Hopkins Transportation and the Baltimore City Scooter Office. I'm not entirely sure that's what it's called, but that's what it's called, to develop geofences to give to the Baltimore City Scooter Office, who would then give those to the scooter companies and say, hey, please don't park scooters within these locations on campus. Fun little geo quirk of this, as you can maybe tell from the map on the right there, is the city then had to buffer our polygon a little bit more to account for the inaccuracies of GPS. If they installed geofences on scooters to exactly our lines, which were more or less our parcel boundaries, people would probably be parking scooters in the street, and that's probably something we don't want to have them do. So generally it works. This little small diagram there, these different colors are the different scooter companies. Those are all the different parkings. It looks like it's doing a pretty good job. That was just a snapshot from, I don't know, earlier this semester. And it was a fun map to make. Next. Oh yeah, that's it. So thank you very much. If you have questions about, facilities and real estate data or campus data, please feel free to reach out. We're extending into different kinds of data and different solutions. So thank you.
Thank you, Jonathan. Up next, we have Casey Lertz and Elena Podzillo at the Kscs History Department.
Hi all, thank you so much for having us today. Our presentation is about a pedagogical problem and solution that we've developed using Esri Storymaps. So I'm Casey Lertz, I'm a professor in the history department. I'm going to frame the problem, then I'm going to hand things over to Ellie Podzillo, who's a grad student in our department, who's been an RA and a TA on this project, who will walk through kind of how we've been solving it, and I'll wrap up by telling you about what our plans are next. So I teach an intro to modern Latin American history survey most years. I love teaching the survey, but there's some major problems with surveys. We have to cover 200 years and 20 countries in 13 weeks. And students always have some complaints. And one of them is that they just can't I can't dive deep enough into particular topics of interest to them. And also surveys aren't the best for teaching research, which is something Hopkins students really want to do more of. And that the Q2 report really has encouraged professors to kind of provide more opportunities around. Also, I'm bored with reading and writing exams that don't always measure the kinds of learning I want students to be doing, and don't help students think about the ways that they have mastered particular skills and kinds of engagement over the semester. So I applied for a Center for Educational Resources grant to put together a new semester-long assignment that would use weekly research exercises and Storymaps mini assignment modules to help students identify a research topic, learn to find and analyze primary and secondary sources, and then present their research and for a general audience using Storymaps. For those unfamiliar, Storymaps is an Esri digital storytelling project that allows users to embed ArcGIS maps and other digital content from around the web alongside text, images, photos, videos, kind of anything you want to, and then guide a reader or viewer through the narrative that they want them to tell. So for us, this is a great way to get students to incorporate lots of different kinds of sources and show us how they're analyzing them and incorporating them into their own learning. This was too much work for me, so I hired Ellie and another grad student, Marlis Hinckley, in the History of Science program to help create the assignments and think through the best ways to structure the class. So if you could move to the next slide, and I'll hand things over to Ellie for the moment.
Thanks so much, Dr. Lertz. Just to kind of get right into it, I was originally drawn to this opportunity to work on developing a Storymaps-based research pedagogy for undergraduates due to a nascent interest in using ArcGIS in digital humanities. Before teaming up with Marlis and Dr. Lertz, I'd grown interested in the field of DH as a member of LifeCode, which is a sort of multi-project digital research collective led by our colleague in history, Dr. Jessica Marie Johnson. This community introduced me to the idea that using digital tools can allow more people to share more information with a broader audience, and can allow us as humanists to expand and defy different conventions around knowledge production. These premises were appealing to me as someone interested in facilitating access to historical education and reimagining the relationship between the academy and academic historians and public history and historical narratives. So from working on a project that was focused on 18th century documents in colonial Louisiana, I'd been in conversations about maybe using Storymaps to reimagine archives and communication. So when the opportunity arose to apply this to undergraduate teaching and modern Latin America, I was really eager to get involved. So some of my goals as a research fellow and TA were to encourage our students to think about form, design, and content as integral components of argument and method. To do this, I developed a scaffolded plan to spend the first half of the semester thinking about different tools and challenging students to consider how the amount of information, animation of information, and use of visuals could add to or detract from or simply alter the materials and ideas that they were sharing. I developed a series of templates on Storymaps that incorporated the different features that platform encapsulates alongside precise instructions for the first half of the semester. As students modified and developed their templates with research findings, we also invited them to look at different exemplary story maps and read articles and posts from the Esri blog to kind of challenge them to think about how, again, form and design were relating to their argument. Over the second half of the semester, we've been working with comprehensive sets of written instructions outside of Storymaps and our sort of weekly worksheets that the students have then gone in and implemented, building from scratch their own story maps. And the supplemental readings have taken a turn towards principles of design, color scheme, accessibility, those sorts of things. All in all, we've been really impressed with how students have used story maps to render their traditional academic research more accessible and to take advantage of the different platforms that Esri and Storymaps has to offer. It's been super rewarding to see students take pride in sharing their projects. We've already kind of dispersed them in the Twitter sphere, and we've also worked, like Adam, in the web application building on a hub site that we hope to use to share more maps and the different research projects that they've been working on going forward. I think Dr. Lertz has posted a few links in the chat if you're interested in exploring some of those sites, but I'll pass it back to her to wrap things up. Thank you.
Yeah, if you could go to the next slide, that'd be great. So I posted a link to the course hub. So we also used the Esri hub feature to build out the whole course website for this class. I've posted a link to the template that Ellie created for students to kind of modify. And then I've posted a sample midterm by one of our students, Bonnie Jin, to kind of illustrate all of the amazing work that these students have been doing this semester. So the class so far has gotten a lot of great feedback from students for the most part. It's definitely a work in progress. And we're going to be kind of revising this as we go forward. There's a lot of work for students in this class, and some of them were a little overwhelmed by it, especially because of the hybrid modality of the class. And just like some of this will be things that we'll do together in class when we are once again in a classroom together, but this semester we weren't able to do that. Some of it is things that we're just kind of synthesizing the reading assignments for the class and the research a little bit more, those sorts of things. So some of it is workload, and the technology side of things was sometimes a little overwhelming and surprising to students who came to a modern Latin American history class, imagining something more traditional. Most have really embraced this sort of public facing digital humanities, digital toolkit that we're giving them, but it's something that we're gonna have to kind of figure out how to better prepare students for in the future. And finally, we're going to work on making these publicly available. We're talking with Esri right now, potentially publishing Ellie's templates and the instructions that go along with them on Esri's site for other faculty to use, or not just faculty, but anybody trying to teach people how to use story maps to use elsewhere. And so that's kind of the next step, as well as hopefully publishing something about this experience and kind of the pedagogical impetus behind it for survey classes and things like that going forward. So thanks very much to Ellie, of course, as well as to Marlis, our other TA or RA, and our TA, Arthur, in the history department, as well as to the folks over at data services at the MSc library, and the students, of course, in this class as well. So thanks all.
Thank you, Casey and Elena. Up next, we have Molly Mantis, who graduated not too long ago from the Johns Hopkins Bloomer School of Public Health.
Thanks, Anton. Hello, everyone. My name is Molly Mantis, and I'm excited to be presenting on my research today, which looked at the impact of spatial variation and access to community health workers on malaria outcomes among children in a high transmission region in Zambia. I'm currently the Monitoring, Evaluation, Research, and Learning Analyst at Last Mile Health, and I recently graduated from the MPH program at Hopkins back in May of this year. And the research that I'm presenting on today was actually my capstone project that I worked on through the MPH program. So I just wanted to start by providing a little bit of background on the setting of this study. So within Zambia, malaria case fatality is highest in Chilenge district, which you can see in the map on the right side of the slide. And in Chilenge, St. Paul's Hospital is the only hospital, and it services all 15 rural health centers in the district. So in order to promote earlier treatment of malaria, the Ministry of Health implemented the Integrated Community Case Management Program back in 2018, which deployed over 300 community health workers into the community. And the aim of this study that I'm going to talk to you about today was to determine whether increased access to care via proximity to community health workers improved malaria outcomes in children hospitalized at St. Paul's with severe malaria. Next slide. So the study was a time-matched case control study with 159 cases, which was defined as children with severe malaria who died, and 380 controls, which was defined as children with severe malaria who survived. And we really wanted to look at the impact of access to community health workers on mortality. But one of the limitations for the data is that we didn't have information on direct patient contact with community health workers. And in fact, we really only had data on the patient's villages and the community health worker locations. So there are kind of two challenges with that this study overcame using GIS tools. So the first is that villages in Chilenge are fairly dynamic, so their names change with some frequency. And we also had some missing village location data. So first, village location, first village names and coordinates needed to be reconciled, which was done through cross-checking against the community health worker data set, and also by consulting with a contact from the district health office. And then for villages without location data, coordinates were assigned by taking the mean approximation of affiliated community health worker coordinates, or also by obtaining some coordinates from Google Maps. And if neither of those were available, they were collected by an ISOMER team member in the field. And then the second challenge was that we didn't have information on patient contact with community health workers. So to overcome this, I created the main exposure variable using a buffer analysis in ArcGIS Pro, which acted as a proxy of community health worker access. So I found the number of community health workers within 500 meters, 1 kilometer, and 2 kilometers of each village. And then based on the distribution of community health workers, it was decided to use a density of community health workers within 1 kilometer of the patient's village as the final variable. And the buffer analysis process is shown on the in the map on the right side of this screen. So the purple triangles are patient villages, and then the green dots are community health worker locations. And the blue circles around the purple triangles are the 1 kilometer buffer around each of the patient villages. Next slide. So once the exposure variable was created, I was able to run a series of conditional logistic regression models assessing the impact of density of community health workers on mortality outcomes. And ultimately, the study found that access to community health workers, which was estimated by the density of community health workers within 1 kilometer of a patient's village, was not associated with in-hospital mortality. And this was consistent across all subgroup and sensitivity analyses. And the negative findings may be explained by a number of factors, including that community health worker access reached saturation, since 95% of patients came from villages with 1 or more community health workers within the 1 kilometer radius, or that children who are most sick still aren't getting treatment early enough. And then it could also be due to other barriers to access to care, like low availability of emergency transport systems and also pre-referral therapies. So this study, of course, had some limitations, such as the exposure variable that was used being a proxy measure of community health worker access, and then also the smaller sample size. And then looking ahead to future studies, impact assessments of ICCM on malaria outcomes should assess utilization of community health workers by directly measuring patient contact with community health workers if possible, and then also looking at specific components of the ICCM program, including commodity supplies and also referrals. And lastly, I would like to quickly thank Drs. Matt Ippolito and William Moss, and also the entire ISOMER team for their support and guidance throughout the study, as well as the other individuals who contributed to the study that are listed on the screen. So thank you very much.
Thank you, Molly. Up next, we have Dr. Amanda Gorton, who is the Grant Challenges in Biology postdoctoral fellow, Department of Ecology, Evaluation and Behavior at the University of Minnesota.
Hi, everyone. Yeah, so I'm probably an anomaly in this group in that my training is actually in ecology and evolution, but I'm really excited to talk to you about some work that I've been doing with Jesse Berman in the School of Public Health at the University of Minnesota, where we've been really doing this sort of interdisciplinary work across public health and urban ecology to look at allergenic pollen in urban areas. So just to give you a little bit of background motivation for this work, for understanding pollen in urban areas is really important for public health. Allergenic pollen like ragweed is one of the leading causes of allergic asthma, which is also the most common form of asthma. And when you think about plants like ragweed that produce this like really allergenic pollen, it's hyper abundant in urban areas. And what previous work in some cities have found is the actual distribution of plants within cities is really patchy. So by that, I mean, some areas have a lot of plants, some areas have fewer plants, which you would think might lead to variation in the amount of pollen people are being exposed to. Yet when you get sort of those day-to-day estimates, like you turn on the weather and you get here's the pollen load for today. That's actually based on only a single monitor for almost every urban area. So what we were really interested in sort of looking at is, are these single measurements really representative of the actual pollen load people are experiencing on the ground throughout an urban area? So specifically, how is ragweed pollen distributed in an urban area? And then secondly, can we identify any environmental variables that might actually be predictive of areas that either have low or high pollen concentrations? Next slide. So for this work in summer 2020, I set up 45 pollen samplers in the city of Minneapolis. These were distributed roughly based on zip codes. There was at least a single pollen sampler in every single zip code. And so that's what this map on this far left is showing you. The red is the boundary of the city of Minneapolis. Each little gray dot represents a different pollen sampler. So then the next map to the right is just showing the raw pollen counts from those samplers, whereby larger circles indicate a larger amount of pollen. And so we found evidence of both spatial dependency and spatial variability in ragweed pollen across Minneapolis. So then what we did next in our analysis is we used universal kriging to actually predict pollen across Minneapolis at a really fine spatial scale of 250 meters by 250 meters. So that's what this final map on the right is. It's a pollen prediction map for the city of Minneapolis, whereby darker blues and purples indicate lower pollen levels, and the yellow and oranges indicate higher pollen levels. And for this analysis, we included several different environmental variables. These were things like land cover. So was it buildings? Was it grass? Was it trees? The percentage of vacant lots in a given prediction grid, mean temperature, as well as NDVI, which is just simply a metric of vegetation. So again, what you can see is there's really spatial variability in sort of high areas of pollen and low areas of pollen. Next slide. So to conclude, we found spatial variability in ragweed pollen within Minneapolis. What I didn't quite allude to in the previous slide is that these environmental variables that we picked were not actually that great predictors of the spatial variability. In other words, they didn't explain all the spatial dependency we saw. So that means either that the variation in pollen is at an even finer scale, so less than 250 meters apart, or there are sort of other environmental variables that might be contributing. And as I alluded to in the introduction, this has really important implications for allergenic disease in urban areas. And it suggests that if we want to accurately capture pollen exposure, we need more than just a single pollen sampler in urban areas. And so our next steps with this project is we're going to be both incorporating census data as well as hospitalization data for asthma. And that's the end of my talk. I just wanted to thank both Guy Robinson and Kate Weinberger, who helped with the pollen sampler design, and the College of Biological Sciences for funding.
Thank you, Dr. Gordon. Next, we have Austin Rao, who's a PhD student at the University of Minnesota.
Hi, thank you all for being here. Yeah, so my project was motivated by, there's been a ton of research done on Lyme disease as a tick-borne disease, which makes sense. It's the #1 cause of tick-borne related illnesses in the United States. But if you asked a random person, what's the second leading cause of tick-borne disease, they probably wouldn't know the answer to that. And the answer is actually anaplasmosis. So that's the motivation for this work, was to really investigate these other important non-Lyme tick-borne diseases and to describe the spatial and temporal heterogeneities and risk of these diseases, specifically within a healthcare system population of an endemic region in the upper Midwest. Next slide, please. So the data came from the Marshfield Clinic healthcare system in Wisconsin that serves around 700,000 people. And this study had a unique advantage in that we were able to obtain the monthly counts of users in the healthcare system. So our incidence rates were much more accurate compared to using census populations for the denominators. And we specifically looked at laboratory confirmed and supportive cases for anaplasmosis and babesiosis over 4 distinct time periods 2000 to 2003, 2004 to 2007, 2008 to 2011, and 2012 to 2016. And we used the SAT-SCAN software with an elliptical scanning window and reported the most likely cluster, spatial cluster generated from the SAT-SCAN analysis. So starting in the left panel, we can see the maps for anaplasmosis, which first became nationally notifiable in the United States in 1999. You can see that there's actually quite a few counties on the boundary of the Marshfield Clinic healthcare system that have 0 cases for anaplasmosis, and most counties are kind of lower incidence. The spatial cluster detected was in this northwestern section of the healthcare system. And then in the next time chunk, where incidence rates somewhat increase but are mostly the same, that spatial cluster is located in the same area but expands out a little bit. It's not until 2008 to 2011 where incidence rates become quite a bit higher that the entire northern third of the Marshfield Clinic service area is the primary spatial cluster detected. And then at the end point of the study period, the spatial cluster shifts over to be the eastern third of the Marshfield Clinic healthcare system. Then moving on to babesiosis, which became nationally notifiable in 2011. It was in Wisconsin. It was first detected in 1985, but for our study population, we didn't have our first positive laboratory case until 2002, which is why that first time chunk of 2000, 2003, there is no spatial cluster to report because there's only 3 counties that had any cases. Virtually no cases were there. It's not until 2004, 2007 that there's enough cases present to detect a spatial cluster in the southern area of the healthcare system. Then moving on to 2008 to 2011, where we start getting more higher incidence counties available, the spatial cluster migrates in a north and western direction. And then at the end of the study period, it restricts down to these 3 high incidence counties in kind of the central and western part. Next slide. So overall, our main results and conclusions were that there's been a general trend of increasing risk for laboratory positive results of infection with anaplasmosis and babesiosis in our study population over time, and that we did find variation in both geographic space and over time, which may be suggestive of a complex infection landscape in this region. And this is only a very small subset of all the analyses that were done for this project. So I put in there a link to the paper. It's been published as a manuscript in the International Journal of Environmental and Public Health Research. And I just want to end by thanking all the co-authors, Doctors Jesse Berman, Claudia Munoz-Zanzi, Jonathan Oliver, Anna Schothofer, and also funding from the Minnesota Futures program that was used. Thank you.
Thank you, Austin. Up next, we have Miro Imagawa, who is a MS student in the environmental health science at the University of Minnesota.
Hi, everyone. So I will be presenting on the work I've been doing for my master's thesis, looking at using wildlife Sentinel data and GIS to identify possible environmental hazards impacting wildlife health and what this could mean for human health and public health efforts. So for this project, we wanted to investigate whether there were possible lead exposure hotspots impacting wildlife by using their blood lead levels and performing an inverse distance weighting interpolation. And the other objective was to evaluate the associations between environmental exposures and variabilities in the blood lead levels. Just a note on the data sources for this project. The animal data came from the Wildlife Rehabilitation Center, who are our collaborators, and they are a full-service veterinary clinic that rehabilitates injured wildlife from the entire state of Minnesota. We had 3 study species, which were Virginia possums, gray squirrels, and pigeons, and our study area focused on 5 counties surrounding the Minneapolis-St. Paul area of Minnesota. Next slide, please. So the first step was to map the locations of the blood lead level samples, which was based on convenience sampling of wildlife. And that is what is seen in map A, with each point's corresponding lead level range. Each point has a specific lead level reading. So from there, I created an IDW map for interpolation purposes to see if we can observe possible hotspots of lead exposure in this area. Map B is based on all 3 species, and Map C is stratified by just possums and squirrels. So we were able to observe that there is spatial heterogeneity of our wildlife blood lead levels, and there may be possible areas of interest that are hotspots for elevated blood lead levels, especially in the center of our study area. Next slide, please. The second task was to map the locations of our environmental variables. And we do have some raster layers that are not represented on the map, which were historic and current land use, as well as population density. So in map A, you see that the road density is higher in the study area center. And then in map B, you also see that the locations of many of the variables are more concentrated in the study area center as well. So then what I did was calculate the continuous distance from each environmental source and overlay those layers with the locations of the blood lead levels to give me a distance to each environmental variable, the population density, and the land use type for each collection point, as well as its corresponding lead level reading. Next slide, please. So finally, with that information, I ran a multiple linear regression, and the results show that looking at all 3 species, there is about a 9% change in blood lead level for every 1 kilometer increase of road per square kilometer of land. And when looking at possums and squirrels, the results show that there's about a 20% change in blood lead level with increase in road density. And when we also just look at 2 species, there is also a percent increase in with population density as well. And the results you see here are the only ones that came out statistically significant. Next slide, please. So in conclusion, the IDW interpolation showed that there may be areas of increased concern where hotspots of elevated blood lead is seen in wildlife. The results suggest that road density and population density may explain the variabilities in blood lead levels of wildlife. A good next step would be to see how the Sentinel data is associated with human health data. And from our results, we could look at areas of hotspots from our IDW maps and see if those are also hotspots of lead exposure for humans, and to see the magnitude of association between animal health data and human health data in lead exposure cases. We could also look at areas of high road density and look at the blood lead concentrations of humans in these areas, as these areas could also be places of concern for human populations and lead exposure. So to close out, I would like to thank Dr. Jesse Berman and Dr. Marcus Rushing for their feedback and advisement through this project. I'd also like to thank Dr. Allison Carter and Dr. Renee Schott from the Rehabilitation Center for letting me join this project, and also for all their insight. Thanks.
Thank you, Mito. Up next, we have Erica Adams, Erica Adams Leonard, who's a DRPH candidate at Johns Hopkins University.
Hey, everybody. Thanks, Anton. It's okay. I'm still Erica Adams, I think, at the university. I haven't got my name changed there yet. All right, good afternoon. Good to be here today. I'm going to talk about the relationship between social vulnerability and exposure to frequent disasters. So just a quick background. Social vulnerability is the collective socioeconomic and demographic characteristics of a community that act as indicators of a community's ability to respond and recover from natural or anthropogenic hazards. Obviously, social vulnerability has more to do than with hazards, but that's what we're going to talk about today. This may be social influenced by multiple factors such as employment or income, education, housing type, age, race and ethnicity, social network, access to healthcare, et cetera. Evidence suggests that socially vulnerable populations are often less prepared for potential disasters and more likely to experience adverse effects during a disaster and slower to recover. However, there's actually been very few studies done really looking at where socially vulnerable populations are proposed to exist and the history of frequency of disasters in our country. So our goal here is to characterize that relationship. We'll assess for clustering univariately and bivariately, and then we'll also look for spatial variation using regression, and we'll assess the residuals, and then finally do a bivariate cluster detection to understand where specific communities might be who are socially vulnerable and high frequency of disasters. Next slide. All right, first, let me quickly go over the data sets we're using. Both of these are publicly available. There's the 2010 county level CDC Social Vulnerability Index. We look at the overall rankings as well as the 4 sub-themes, which are socioeconomic status, household composition, race, ethnicity, and language, and household and transportation. Those are 4 sub-themes that are in total, sub-themes that are in total made up of 14 census-based variables. The index this index is already heavily used by state and local agencies. And since my goals here are to understand how we can target policy, that's why I like using something that's publicly available and already in use, because then it's easy to translate into additional use later on. And then for the, excuse me, for the FEMA disaster disaster data, we are using FEMA disaster declarations from the years 2014 and 2016. So the SVI is kind of centered in the middle of those years. And this way we can have a large swath of time to understand, where there are areas that have a lot of disasters versus those that have very few or none at all. And so those are the 2 maps that you see on the screen now, just an overview, a choropleth overview of exactly what they are. If we do an exploratory analysis of using univariate global Moran's eye, we see that there is spatial dependence and clustering in both the SVI and disaster declarations respective of each other. Those are actually pretty high Moran's eye values. And then we use the LISA statistic to identify where there are hot and cold clusters also respectively. If we just do a visual inspection of this, I mean, you see some overlap. Definitely there's some southern areas that are high and some sort of north central, northwestern areas that are cold. So there's maybe a moderate spatial relationship implied here, but we'll do some additional analysis to characterize that further. Oh, sorry, I forgot to say next slide. So the maps I was just talking about are on this slide. You can see that there's the hot clustering in the base of both of them, and cold clustering sort of in the north central areas. But again, this implies maybe a moderate relationship just upon visual inspection. Okay, next slide again. Sorry about that. I have my notes on a different screen. So there's a lot on this, and I know they're going to disperse these, so hopefully you guys can look at it a little bit more later. What I tried to do is lay out the takeaways in that light blue box on the right side. Basically, there's an overview of some of the models that I ran. The takeaway here is that we generally see a strong, significant relationship between the various forms of SVI, whether it's the sub-themes or the overall SVI, and FEMA disaster declarations. We ran Moran's eye parallelograms on the model residuals to test for spatial autocorrelation. And what we found generally, so if you look at those top 2 parallelograms, you'll see that the model didn't really account for much of the spatial variation in overall SVI. But if you look at the bottom one, and that's what most of our models look like, space didn't really account for much of the autocorrelation. However, in model 7, which is the one where we're looking at race, ethnicity, and language, we do see that the disaster declarations accounted for some small amount of spatial variation in that theme. So I think that's an interesting finding, that minorities and those who speak English less than well, which are the 2 census variables included in that theme, are somewhat spatially linked to areas that are potentially more prone to disasters. So there's certainly implications there for what's going on in relationship to environmental injustice or health inequities, things like that. And I think that warrants further research so that we can better understand, at a minimum, how to communicate better with those populations before, during, and after disasters. Next slide. So finally, using the bivariate LISA statistic, we see that there are hotspots of counties generally in the southeast and southwest, so southern regions of the US. And I think this is the most application-based output of this work, is that we can actually see, okay, these are counties, these dark red counties are ones we know have high social vulnerability according to the CDC SVI, and have a high frequency of disasters in the past, over that 13-year period. And so it tells us that these are specific areas that we might need to target for resources or funding or policy development that might help those populations better prepare for and cope with disasters. Next slide. So our main results and conclusions, social vulnerability and exposure to or frequency of disasters are significantly associated. There are hotspots of areas high in both social vulnerability and frequency of disasters, generally in southern regions of the US. And this work was really done to set a baseline to understand what the relationship between those two are so that I can look further into these other things. So my next step will really be to understand how that relationship also affects the health outcomes in those areas. Do we actually see an increase in health outcomes, and what does that mean for health inequity in those areas? Additionally, what is the capacity to respond to disasters and care for populations in those areas? So what are people's access to care? How well funded are state and local agencies, such as our public health departments and emergency management departments, so that we can better understand how we might target those areas for resources and what types of resources those areas might need to cope with what will likely be an increase in intensity and frequency of natural hazards as we move further into climate change. So that's kind of where we're trying to go with this. And I think this was a good starting baseline for that. And I think that's my last slide.
Thank you, Erica. Up next, there we go. Up next, we have Sri Banerjee, who's a core faculty at Walden University College of Health Sciences.
Thank you. Thank you for having me. Can you hear me?
Yep.
Okay.
Hear you well.
Okay. Yeah, so thank you for having me another year of GIS Day lightning talks at Johns Hopkins University. I'm Dr. Sri Banerjee. You know, I was here last year as well, and this year, as I was trying to think about what to prepare the talk about, I was debating, you know, because I've been working on several projects with my colleagues regarding some geospatial considerations, and I was thinking maybe something different, but what I decided is that the multi-scale geographically weighted regression is so powerful. It's such a nice tool to use, especially when there are variations to be considered. And so I'm going to go into a little bit about the multi-scale geographically weighted regression that I used in this project. So just going down what the objectives we'll be going over, you know, applying the OLS regression and spatial models to explore impact of location. So just traditionally geographically weighting how that helps regression models in terms of predictive accuracy, things like that. And also comparing the model fitting. So I'll be showing you comparisons of the Akaike information criteria for model diagnostics, comparing several types of models. So trying to then draw the connection between how you make a map and then how you apply that to policy implications. After all, with the pandemic, you know, a couple of things have really emerged. One is the importance of policy for public health, but also the importance of equity, and the importance of understanding social disparities in the context of social determinants of health. And you know, I would argue that mapping is a powerful tool to be able to study social determinants of health. So I'm going to go more into that. And the multi-scale geographically weighted regression model is perfect for understanding some of the parameters and complexity of social determinants of health. So if we could go on to the next slide, please. Okay, so there's not a lot going on here, but I started off with kind of a general map understanding the distribution of breast cancer. Again, this technique is being applied to breast cancer incidence rates. So the model, actually, the eventual model was using age-adjusted incidence rates of breast cancer. So that was what was being modeled as the outcome dependent variable. Now, the independent variables, there were several that were loaded into the model. One of which was the number of the number of days of heat. Heat waves, things like that. Does that make a difference when we're thinking about cancer epidemiology? In terms of, particulate matter, inhaling particulate matter. Last year I had presented on lung cancer, and of course, you would naturally think that there's an association, but I was trying to look for, if there's an association with breast cancer. And so the findings demonstrated that, in fact, there were significant associations when you applied this multi-scale geographically weighted regression. And so some of the summary estimates have been provided on the screen. However, there are local level estimates that then are mapped in order to then demonstrate where policies can be placed. So tailored policies can be created here. So if we can go on to the final slide, I can kind of explain all of this. So, I said a couple of things. One is that not only were the predictors significant, and so again, just going over the predictors, there were 4 predictors: poverty rate. There was the Gini index. So Gini index is a robust measure for income inequity, which is a little bit better than just looking at poverty rate. And then, of course, particulate matter. And then I went over the number of heat days. So these were all significant. But what was more important is the fact that how well did the model predict? How well did it perform? And I'd say at the beginning that I was going to tell you about the Akaike information criteria. So, when we looked at the global scale, not, really taking into consideration some of this weighting, then the value ended up being a little over 2,000, right? So the smaller the value, the better the model is fitting. So if we looked at the then model 2, which used traditional geographic weighted regression, then I actually did not include the value there, but it was actually 1836.5. Then model 3, including multi-scale geographic weighted regression, that was 1798.6. So definitely functioning better. And so the implications of this is the fact that at a local level, we can create tailored interventions that are more predictive of certain diseases than others. So for breast cancer incidence, if there are certain variables that are more applicable at a community level, then interventions may be tailored towards those, and we can bring in things like Healthy People 2030 and others to try to understand how to guide these. Thank you for listening.
Thank you. So we don't have too much time. I don't think that there were too many questions, but I do want to give a chance, maybe if anyone has a question or if they want to bring one up now.
Yeah, I have some questions. Sorry, I was co-host, so I wasn't able to ask a question in the Q&A box. My first question is for Molly. I'm just curious about the justification of using the 1 kilometer buffer to look at access, considering people in that region or in Africa in general tend to go very far distances to reach healthcare.
Thanks, Michael. So there were a few reasons why we chose the 1 kilometer radius. One was that it had the most it had the most variation in frequencies of community health workers for patient villages. Another is because it had a very low amount of patient villages with 0 community health workers, which we saw when we lowered the kilometer radius. And also we thought that 1 kilometer was a reasonable walking distance from patient villages.
Have you looked at other modes of transportation or looking at the road network to look at maybe a little more accurate estimates of travel impedance?
Yeah, that was something that we were thinking about looking at if we took this study further. We don't have great data on road networks in that region, but if we did have better road network data, that was something that I was planning on looking at, and I'm sure that as that data becomes more available, it would be something really good to look at in the future.
Great, thank you. Yeah, I wonder if OpenStreetMap has any road network data for that region. That's what I tend to go to in areas that have limited GIS data, but yeah, thank you.
Thanks.
I had a question there were a few people that worked on dashboards, and I was just curious because I feel like dashboards have become very popular, especially maybe because of the popularity of the Hopkins COVID dashboard. And so I was wondering, it seems like a lot of people have been using ArcGIS and ArcGIS tools, and are there any components, and in this kind of world of interactive dashboards, are there some tools that you wish you had, or some kind of possibilities that the dashboards are limited to, that in your search when you were selecting the software you wish you had? Or maybe you found the perfect software and everything that you wanted to accomplish was pretty much already built in.
I know that one limitation I've had with ArcGIS dashboards is you have to manually keep your color theme of charts and graphics and stuff, and you have to manually enter that stuff in, right? So if you got a bar chart and you set up this color symbology, you have to then manually enter in those color codes, etc., for the next chart. I'm pretty sure, we're using Portal and not ArcGIS Online, so we might be behind on an update. But I feel like, if you're doing 1 or 2 colors in one graph, that's good. But sometimes you need to have a little more complex, and it's kind of a pain, right? To have to manually copy over those attributes. Where you think, well, if it was something like, if I was doing this from scratch in D3 or Leaflet or something, I could just pull all that from a library, right? Or a dictionary or something like that. Like, these are my colors, look them up. Yeah, that's one pain point I've had with dashboards for me personally.
I think, Anton, we had similar issues with the COVID syndromic surveillance dashboard, where we had to reach out to Esri to get this custom function to dynamically update our color schemes and legends every day, since we were updating data every day. We would have to do that manually until we were able to get it automated. So I think if you were to reach out to Esri, they might help you automate that, so you don't have to manually do that.
Oh, sure. If you reach out to Esri, they'll help you with anything.
Yeah. Well, we got lucky with that.
That's true. Well, you guys got a lot more attention for that kind of stuff than than general users probably.
We might have a time for one more question, I think.
Actually, I have another question for this time for Austin. Well, I have a few, but I'll just ask this one. I'm just curious if you considered using a multivariate scan statistic to look at simultaneous excess incidence of both, say, anaplasmosis and other non-Lyme disease diseases in that region.
Okay, so by multivariate, including some predictors maybe to see if that could change the spatial cluster locations?
So in StatScan, you could look at multiple outcomes. So you could look at simultaneous excess incidence of, say, anaplasmosis and babesiosis, where they kind of co-occur in space and time, rather than looking at them separately.
That's a great suggestion. I wasn't aware of that feature. And I think for at least this initial project was just getting something out there, because there's just so few work that's done on these two diseases, especially, so I think this was a good initial pass, but yeah, in future work, I think that could be an interesting avenue to explore.
Yeah, thank you. It's good to see that work is being done. I was just curious because I've done similar stuff with like dengue and chikungunya, since they're both caused by a mosquito. It's good to see where they're both kind of co-occurring in space and time, and StatScan is a good way of doing that. So just an idea. Thanks. Yeah.
All right, and it seems like we're pretty much running out of time here. So I want to thank again all the panelists. I think this was a great, very interesting presentations. I want to remind everyone that this is recorded and it will be made available on several sources, and we'll send those out. I want to thank again our co-sponsors, the Center for a Livable Future and the Spatial Science for Public Health Center. If you're interested in learning more about either of the center, we'll also drop the links for those in the chat box or send them out. Okay, thank you everyone, and enjoy the rest of your day.